Welcome to our lecture on marginal bone loss and Peri Implantitis. The problem happens when we have contamination of our implant surface or the SLA surface, and this happens when the implant gets exposed to the bacteria from the outside. You really need to place your implants according to the tissue thickness in place, and if possible, place the implant abutment one time during surgery, during surgery placements. Often we do that in full arch surgery where we're placing the multi-unit abutment and we're never disconnecting it. There have been some newer concepts in which this is also done for single tooth implants. According to the 2017 World Workshop on Peri Implantitis, there's a number of evidence linking Peri Implantitis to other factors. It can be such things as the use of cement, which can get underneath the tissue. Sometimes the lack of peri-implant keratinized mucosa is a big factor in terms of cleanliness of the area and in terms of home care for the patient as well of the dental implant. As far as classifications, it really depends on the severity of the bone loss that's happening. It can be split up into early, moderate, and advanced cases, and it really depends also on a number of factors like the probing depth. Usually you'll have bleeding or a suppuration on probing in these cases. When it gets to be really advanced, then you may have extensive bone loss requiring removal of that implant. As far as classifications go, you have implants split up into retrograde peri-implantitis. You also have infections that occur or can be also to overload. So examples of retrograde, basically, you have your implant placed and then you have an infection occur potentially due to an endodontic lesion in the bone that may necessitate, as you can see here, resection of the implant. It can also be to overload from function, or it can be due to infection or exposure of the threads over time of that implant causing subsequent bone loss. So these cases can also be split up, like I mentioned, into mild, moderate, or advanced lesions for the RPI classification. And as you can see here, we ended up doing a resection of the implant in order to treat it with resolution of the lesion. How about in the control of occlusion in these cases? So when there's an implant tendency increasing beyond 180 micrometers, then you have potential bone loss occurring. So you don't necessarily have to have inflammation or even any infection in place. It's simply overload of the implant causing bone loss over time. And you can see here a histology demonstration showing an increase of the occlusal load on the implant, and over time you can see subsequent bone loss or loss of support around that dental implant. Again, demonstrating the same concept here as well. Really what happens in terms of biological width, we act to have a barrier around our implant to protect our implant as far as avoiding that bacteria from infiltrating around our implant. So what happens when we break that junctional epithelium repeatedly around our implant? Well, we're going to get marginal bone resorption. And we can see that in this study here, where the test abutment was removed and reconnected multiple times, that you do have first an establishment of the biological width on the first connection of that test abutment. And then after that, if you keep connecting and reconnecting it, you do get to have a bit of bone loss that occurs with each connection and disconnection. So within the limits of this study, the connections and disconnections of those abutments did have an effect on the bone loss or the marginal bone levels around our implant. So what does that mean in the long run for us? So if you have your implant placed and you've connected your healing abutment and now you've taken it off and you get some bleeding, which can usually occur with disconnections on first disconnections of the abutments. And when you go back, you notice some funneling or loss of bone around the implant. Well, that's a cascade or potential start of that problem that can lead to the cascade of peri-implantitis. So we need to find a solution to this and how to prevent it. So we're going to discuss that next. So you can see here, once you have that potential exposure of that SLA surface and that bacterial infiltration down the implant, that can continue with time and cause issues. Another big factor is the shape of our healing abutments. If the healing abutment is not seated fully down, you can have potential looseness of that healing abutment or impingement on the bone, leading to bone loss and again causing potential peri-implantitis. So if the biological width is typically about 3 millimeters and we have a millimeter for the sulcus, the junctional epithelium, and a millimeter for the connective tissue, what does it mean in terms of tissue thickness for our cases? So where sites in which the ridge mucosa thickness was less than 2 millimeters usually ended up having bone resorption. So we need to look at ways to resolve this. So in another study, they looked at the abutment height influencing the effect of the platform switch on peri-implant marginal bone loss. And they basically looked at cases in which 4 millimeters led to 0 bone loss, and cases in which you had 0 to all the way to 2 millimeter, you had bone loss. So why did that happen? It's because we need to look at the depth of implant placement according to the mucosal thickness. So you either need to thicken your tissue or you need to place your implant subcrestal in order to accommodate for that biological width formation. So you can see in this beautiful diagram here, we're illustrating the depth of implant placement according to our tissue thickness. So you need to measure this at the time of implant placement and place your implant appropriately to the corresponding depth in order to have a protective barrier for your implant. In another study, they had 25 patients receiving 2 non-splinted implants, and they looked at the soft tissue thickness measured electronically, and they basically placed one implant at the crest with mucosal thickness of 3, and then another implant depth with a mean thickness of 1.9 millimeters. And what were the practical findings from this? Basically, that when they had the implant exposed at the crest only, you did have bone loss. But when the implant was placed subcrestal to accommodate for that tissue thickness, you ended up having no bone loss. So you need to have the implant placed at the appropriate depth to anticipate early bone remodeling that could happen with that vertical tissue thickness not being quite at that appropriate level that you need. And when you had short abutments that were placed equicrestally, and then you had that long abutment to be placed at 3 millimeters, implant shoulders were placed typically 2 millimeters subcrestal in order to avoid having that abutment exposure due to the thin mucosal tissue. So to illustrate what that means, again, we can look here. We have our implant placed from 1 millimeter depth all the way to 3 millimeters depth subcrestal. And you can see here at follow-up at 1 year, you did have subsequent bone loss at the group with 1 millimeter versus 3 millimeters. Why? Because the tissue thickness was not thick enough in the 1 millimeter group. So you can see here again, if we're not paying attention to our tissue thickness, you place your implant simply at the crestal level, even with grafting of the area. When you come and place your healing abutment or you follow up over that year period, you do end up with that remodeling despite placing our implant in a very nice position originally. But the vertical position of the implant needed to actually be subcrestal. Okay? So compare it to this case here on the left where the implant's placed subcrestal and restored, you do not get that bone loss and potential exposure of our SLA surface. So the solution is to avoid SLA contamination by submerging your implant according to the thickness of the tissue, and if possible, a one abutment, one time protocol to minimize connecting and disconnecting those abutments. So what is peri-implantitis? It's a chronic inflammation due to the SLA contamination. And if the SLA surface becomes contaminated, there's no way to potentially decontaminate it fully. So it's better to seal the area with that junctional epithelium on multi-unit abutments if possible with one abutment, one time protocol, and place your implant at depth according to the tissue thickness. So this leads to the zero bone loss concept. This is Dr. Thomas Linkovich, and he discusses this in depth in his textbook as well. So this is not so much about platform switching or not, because these are not certainly the only issues in place, but having an awareness of our implant depth at placement and the tissue thickness will help to prevent these issues. So if the tissue thickness is 2 millimeters or less, expect that you will have to either place your implant deeper or potentially thicken the tissue at placement with either autogenous connective tissue grafts, or you can use other products like alloderm. So like we mentioned, you can place your implant deeper, and that in essence also thickens the tissue, or placement of other acellular products like alloderm. So we know now that 1.5 millimeters of mucosal height is not enough in these cases. We need to go to 3 to 4 millimeters in order to protect our implants in the long term. So here's a nice example, again, illustrating why we need to place our implants subcrestal in order to reach that appropriate tissue thickness in the long term. And what does it mean in terms of abutment selection in these cases? Well, you don't want to have your abutment very close to the bone level and causing impingement on the blood flow around the implant and tissue in that area. So you really want to select abutments in the 2.5 to 3.5 millimeter height if possible, and that way you also have enough tissue protecting around your abutment to implant interface. And there's a very nice study here about the correct abutment height selection where they varied the shapes of these abutments. And essentially, they found that having a nice implant platform switch with a flared collar shape was the best in terms of preserving the implant bone around that area. So just keep in mind what you're connecting and disconnecting around your implants in the future to prevent issues. Okay, so you want to make sure your implant's not placed too shallow, or you can get kind of this kind of ledge or ridge lap design, which ended up to subsequent bone loss and eventual loss of our implant. So lap communication is very critical in these cases. Thank you. I hope you've enjoyed this section on peri implant.